Lokesh, good evening.
Yeah,
Welcome back again.
good evening, Nihaal. Yeah,
We welcome back Dr. Bolthauser after a short break. Dr. Mankad, hello.
Hello.
belated many happy returns of the day, Kesh.
Thank you very much.
All right. Yeah, I think we have the Nagpur. I think Dr. Shika is there and Rohan. So without further ado, welcome back, everyone. Once again, thanks for everyone who are sending their cases and joining in to our bi-weekly sessions. Special thanks to the panelists also taking out their time and joining our sessions. I think we have around 7 cases today, all new cases. So without further delay, the chat is open for everyone. Please put in your suggestions and comments, and I'll hand it over to the group from Nagpur. Rohan or Dr. Shika, if you're there, please go ahead.
Good evening, sir.
Good evening.
Yeah, we have joined.
Yes, sir.
Yeah.
Good evening, sir. I am today presenting a 7-year-old female presented with high-grade fever since last 3 days, vomiting since last 3 days, and altered sensorium since 1 day. She had no history of seizures. She is a known case of sickle cell. She had GCS of 9/5. Pupils were reactive, for brisk replacement, signs of meningeal signs were present, neck rigid was present, Kernick's Brodinski's was present. So we initially labeled her as meningoencephalitis with signs of raised ICP in a case of sickle cell anemia. We did an LP.
You want me to show the images
there were
first?
400 cells, 90. Yes, sir.
Okay, I think we have 2 or 3 sets of images. So this is the initial one. Once the child presented on diffusion and ADC sequences. The main findings you can appreciate on diffusion are some areas of restricted diffusion in the cerebellar hemispheres on both sides. There's a mixed pattern of edema. Some areas demonstrate facilitated diffusion, but yeah, there's overall edematous changes. Some prominence of the lateral ventricles. There is reduction in the caliber of the fourth ventricle with some pressure effect on the dorsal aspect of the brainstem. On the flare sequences, you can appreciate there is some degree of hydrocephalus with periventricular interstitial edema and cerebellar edema on both sides, as demonstrated better on the T2 weighted sequences. There were no hemorrhages on the SWA sequences. Post contrast, very minimal enhancement, possibly of the inferior hemispheres, but no meningeal enhancement in terms of the supratentorial brain, no ventricular enhancement. As you can see, there is only some degree of leptomeningeal enhancement along the inferior hemispheres, cerebral hemispheres. In terms of tonsillectopia, I think it's within the normal limits. So there's no downward herniation of the tonsils at this stage. So with this, I think the imaging is your prime findings are cerebralitis causing a pressure effect on the fourth ventricle and the supratentorial ventricles causing the hydrocephalus. So imaging differentials are varied and wide, as you can see out here. With that, I'll hand it back over to Rohan with the follow-up lab investigations.
Yes, sir. We did an lumbar puncture. In that, on day 1, we got a cells of around 400 total TLC count, 95% lymphocytes with 5% of neutrophils. CSF blood sugar level was 52. CSF sugar level was 52. CSF2 blood sugar level was 0.42. CBNAT, AFP, gram staining was negative. Cytology was negative. And the total counts were around 31,000 with 83% lymphocytic predominant. Dengue NS1 was positive and blood culture was positive for Burkholderia aphasia. And second thing, like on day 1 with anti-raised ICP measures, our sensorium improved. But since day 1 to till day, the sensorium is same after improvement. Like the child is still lethargic, drowsy, with some obeying of command, and still there is central hypotonia. There is residual weakness.
Okay. So after that, you got a follow-up scan, is that right?
Yes, sir.
Okay,
so
so
we
this-
repeated it after day 4. Yes, sir. Day 9.
Yeah. So 9 days after the initial scan, again you can appreciate almost similar pattern of changes in the posterior fossa, causing compression on the CSO spaces and supratentorial hydrocephalus, as highlighted on the first images. Again, no hemorrhagic changes, no new changes in terms of hemorrhage in the cerebellum. A spine study was done, but only SAT sequences were available. There's possibly some degree of hyperintensities in the cervical cord out there. So without an axial corroboration, I'm not certain, but it appears to be there is some degree of hyperintensity in the cervical cord. In terms of enhancement, cord equina, there's no significant enhancement, no focal lesions in the spinal cord. Yeah, so these are the two sets of images. And yeah, Rohan, you have any, what was the main queries and questions regarding?
Sir, first thing, sir, the hydrocephalus, is it very significant? Should we intervene this surgical intervention is required for this? Second is, any other possibilities we should explore for cerebralitis causing so much of hydrocephalus on day one of presentation with cerebralitis?
Okay. You haven't got any organism on the labs, right? Or Burkholderia is
No, sir.
only
Yeah,
only blood.
Burkholderia, it was positive on blood culture. We did CSF biofire also, it was negative.
Okay. I'll open the case if anyone has any other.
The
Se-
intervention depends on Sridhar here.
Yeah, sure, go ahead.
So intervention depends on how is the child. If he's having signs and symptoms of raised ISDP, maybe you will have to intervene. Otherwise, if he's stable, then no. The Burkholderia is a capsulated organism. So sickle cell disease patients who have autosplenectomy, they are prone to this capsulated organisms infection. So that explains the thing. So I think he should be managed aggressively for the sickle cell part of it. What is the HBS level? Is it more than 30, less than 30?
Sir, HBS level is 72%, 72.8.
Mm-hmm. Yeah, so the HBS levels are very high. So maybe he's most likely going into autosplenectomy, which is explaining the Burkholderia infections. And Burkholderia infections do have this, and sickle cell is also prone to press-like changes. So I don't know whether it is a cerebellar press sort of thing or it is a cerebellitis sort of thing. Because cell count sugar protein is normal in CSF. No, it's not
No,
normal.
sir.
Okay, you are a high sugar. Okay.
Yes, sir.
Yeah. Okay, I love sugar and high protein.
Yeah, protein.
I wonder whether you have given steroids in the acute phase.
We
I
gave
mean,
low doses.
cerebellitis leads to a kind of a swelling, and depending on your anatomy, you very often have early hydrocephalus, and you can also have doncellar ectopia. So this is a general comment. So it's not that unrisky to do a lumbar puncture before you do the imaging. But now in this case, perhaps I think it was justified. But this is, I think, rather unspecific.
How is the child clinically?
Sir, clinically, after initial day one of after anti-raised ICP measures, sir, GCS improved to 14/15. Currently, the GCS is 14/15 irritable. Tone is normal to hypotonic. GAG is absent, sir. Drooling present. Central hypotonia is there. Reflexes are currently absent with power of around 3/5. Some cerebellar signs are positive, sir.
You are giving acetazolamide and all those things to decrease the CSF production.
Yes, sir. Yes, sir. Initially, we gave 3% NaCl and mannitol. That now currently is on acetazolamide and glycerol, oral glycerol.
And the hydrocephalus is significant only.
Yeah, it's causing edema. Even the cerebellar changes in terms
And mark
of
effect.
the edema has increased on the interval scan. You see, this is the initial scan, and then here you can appreciate it has increased.
So the HBS is very high. It's,
Yeah.
more than 30. Maybe partial action, as Anas told, would have been considered. But yeah, we never knew that it will. It's I don't know. In literature, I'm not aware whether sickle cell presenting with cerebellitis is it because of organism or is it because of any other reason, hemodynamic instability.
But the cell counts and all are more in favor of infection along with glucose and protein levels. So we were just wondering what infection it could be and whether it was so early presentation of hydrocephalus. So that was also another thing. And whether these changes are mimicking any sickle cell complication. That was.
The early hydrocephalus is a known complication of cerebellitis. It can come very rapidly within 24 hours. And as already Sridhar discussed,
The intervention depends on the clinical, because within 3-4 days or 1 week, edema reduces. If it is non-infect, sort of not a bacterial infection, you can consider steroids that will reduce edema. But if it is a bacterial infection and the sickle, probably you'll wait for the steroids.
Do you give pulse steroid? Should we try, or we have given like a oral steroid, basically like
Pulse steroid, but with the Burkholderia capacia in the system, it's always risky to give that high dose steroids. So probably you'll have to manage the infection, do partial exchange, supportive care. If it is worsening, sometimes even just doing small decompressive, posterior fossa decompressive craniectomy should be more than enough.
okay, thank you.
Yeah, if I may add a couple of things.
Yeah, Nish, go ahead.
Yeah. So first thing I think seems more like a cerebralitis causing an obstructive hydrocephalus at the fourth ventricle. Now, if it is viral, what I'm aware of, CSF biofire usually does not test for most RNA viruses. So that could easily miss some RNA virus. Second thing, I've seen a couple of cases, especially of posterior fossa, where there may be a component of bacterial infection with ventriculitis, where the lumbar puncture CSF is biofire negative, but after an EVD was done, the biofire came out positive. We recently had a case a couple of weeks back in our hospital. So if the hydrocephalus is increasing, probably the child may need to be intubated and an EVD may need to be done to decrease the pressure, and then you may get another biofire.
Would it be picked up in like imaging findings, ventriculitis? We have done contrast and all. Is there any like little bit suggestion of this thing?
Not on the first scan. I think second scan, I don't have a contrast of the brain.
Yes, exactly. That's why I asked if there was a contrast flare, but it's not there.
Yeah, this is only contrast P1. So yeah, I mean,
Yeah, that's the first scan.
yeah, the first scan. Some on the diffusion also it's picked up usually on the ventricular lining as, but that wasn't there at least in this scan. Okay. Dr. Shika, anything else or?
Yeah, I suppose it. Thank you. Yeah.
Yeah. All right.
Thank you, sir.
Okay, Ron, what do you?
We next have a 16-year-old female from Gadchirali. She initially presented to us 1 year ago with symptoms of continuous fever, weight loss, poor appetite, and altered sensorium quadriparesis with the cranial nerve palsy. When we did the lumbar puncture, the cells were total count were 85% lymphocyte and 5% neutrophil. CSF CBNAT was positive for rifampicin sensitive TB. Our protein was around 282.9 and sugar was 80.4 1 year ago. Then she was under follow-up again 1 year, 1 month back around July. She again presented with severe headache with signs of raised ICT. We repeated the scan, which showed increased hydrocephalus.
Okay, Ron, let me just show the first scan. We'll take it chronologically. So presented in 2024 with symptoms of fever, weight loss, vertebral cranial deficits, raised ICP signs, and tubercle meningitis on LP. And this is the imaging in June 2024. Again, similar pattern as was seen in the previous study. Some cortical edema seen in the cingulate cortex, but you can appreciate hydrocephalus with periventricular edema. Some focal areas of restricted diffusion along the posterior aspect of the spine of the corpus callosum. Yeah, you can also appreciate the fourth ventricle is also dilated on the axial sequences here. On contrast sequences, you can appreciate these punctate nodules in the posterior fossa, especially in the cerebral hemispheres on both sides, also involving the brainstem, as you can appreciate here, lining the roof of the fourth ventricle. So multiple tiny likely tuberculomas demonstrated on the contrast sequences. I don't think there was any abdominal, and also the cranial nerves demonstrate enhancement, as you can see out here. Dr. Lokesh, yes, wanted to add something? Okay. Yeah, after that, TB got a diagnosis of
After-
TB main mucosal with hydrocephalus and raised ICP signs. And then
Yes,
after
sir.
that, yeah.
Then again, she presented with poor oral intake, weight loss, vomiting, and there was history of stop medications for around 1 month. Like initially, the child has reduced herself AKT from 4 FDCs to 3 FDCs. Then there was the signs of proximal myopathy. Grover sign was positive, and we resumed full AKT with pyridoxine. At that time, we did an LP, which showed zero cells, negative for CBNAT. Then on third admission in July 2025, she presented with epigastric pain, severe headache, uh, with the signs of raised ICT. So once again, we
Got a scanner. Okay.
yes, sir.
So a year later, again hydrocephalus in terms of edema compared to the previous study is slightly less. But you have this focal abnormality out here around the middle aspect of the middle, yeah, over here, and again the fourth ventricle is significantly dilated, and some abnormalities also in the CSS spaces and the cysternal spaces, which will be better appreciated in the contrast sequences. Post contrast, you have granulomas along the CSS suprasphincter cistern, the basal cisterns, better appreciated on the SAT sequences. The fourth ventricle is inferiorly, it appears to be trapped out here, at least along the inferior aspect. There is the aqueduct is patent, but there is some septations which are causing obstruction to the flow of the CSF. And you can also appreciate there is a nodal enhancement out there in the floor of the fourth ventricle. So new lesions, especially in the extraaxial spaces. On the spine sequences, you have this long segment myelopathy involving the entire extent of the spinal cord. The cross section, almost the entire cross section of the spinal cord is demonstrating these T2 hyperintendence changes. On contrast sequences, you have enhancement along the dura and also along the cauda-equina nerve. It's no focal enhancing lesions in the spinal cord, though there are some slightly higher hyperintensities, especially in the thoracic cord, but yeah, they don't enhance on the contrast sequences. Yeah, after anything to add, I think we have one more scan.
Yes, sir.
Nothing new, no new symptoms, no?
No new symptoms, sir.
Okay.
Like her pain, severe headache is still persisting with so we did the next scan also.
Yeah. So next scan interval. Sorry, I didn't get the interval time frame one, but the changes look similar. I only put out the contrast sequences. You can appreciate again those enhancing lesions are still persistent, and hydrocephalus is still persistent with the spinal cord abnormalities. So the two main queries which they had was, is this a paradoxical reaction on iris or a reactivation of drug resistance TB? Anything to add, Rohan?
Yeah, actually, mostly it is
Yeah,
like paradoxical worsening, but we have
yeah.
a lot of TBM nowadays, and with all sorts of drug defaulting in between and all. It sometimes, so we were just wanted to discuss this case. What are the radiological correlates of like paradoxical reaction versus the, worsening or progression of the disease? And yeah, because most of we have sent the CBNAT, which came negative this time. Cells are only 10, and we are not getting much evidence of infection. So we are in favor of paradoxical worsening, but we thought to discuss about this radiological findings about.
All right, case is open. The panelists and others to comment upon. Let's see.
I have two simple questions. I have no experience with TB meningitis. My first question is, what are the indications for ventricular shunt in marked hydrocephalus? And the second question or comment, if you do a lumbar puncture and you have complete adhesions, your sample may not be representative. I mean, you still may have some bugs around, but outside your compartment.
Right.
Yeah, actually, VP shunt was not done. We tried to loop in the surgery team. They're trying to loop in, but it's not done as of now. And yeah, regarding adhesion parts, we have not looked into it. But maybe we will try to re-look it, from that perspective. Is there any specific findings for neurological, Dr. Nihaal, where we can say, yeah, this is more in favor of paradoxical worsening, or whether it is like progression of the disease? Are there any specific radiological markers?
I think based on treatment, there's progression in terms of lesions. These lesions were not there in previous scan.
In paradoxical worsening, also we get increase in the
Yeah.
lesions, tuberculosis, and all.
Yeah.
Here comes the dilemma, because in our population, a lot of defaulters will be there. Like this child, they skip the medication altogether for 1 month, and then we restarted in between. And now we are not getting anything in the net. Although we have sent the pyrosequencing, we don't know after so much of treatment if still there will be, we'll have we'll get something out of it. It's
Yeah, Rohan, you want to say something? You raised your hand. Sorry.
No, sir. No.
Okay. Is the child on thalidomide or infliximab, Dr. Shikha?
no, she is not.
There's
I
some
think
suggestions on
thalidomide
the
can be
chat.
tried
Yeah,
for this
yeah.
child because of worsening tuberculomas. Anyways, there is hyperinflammation, whether it is caused by most likely paradoxical reaction or drug-resistant TB. If the initial was drug sensitive, unlikely to be changing to drug resistant in the same body organism, but a rare possibility. And the increase in size of granuloma, increasing edema, new spinal cord lesions which are not there in the first, most likely looks like a paradoxical reaction. So I think steroids should be continued for long, and TNF alpha inhibitors could be added, which would decrease the inflammation. If there is a fourth trapped ventricle or worsening raised ICP, then maybe a EVD or a shunt might help, or new worsening clinical deficits.
I think in this sort of situation, because it's almost chronic hydrocephalus with still periventricular lucences, a shunt will work. EVDs, the short reservoirs, actually are not helpful. So they end up requiring shunt surgery. That is a better thing to do rather than 2 procedures.
Yeah, agreed. Shunt to a TBMH, the Valor grading can be used, and yeah, can be gone with shunt. Will train better.
Okay.
So, yeah. Let's see if any other thing on chats. A question: what's the endpoint for treatment of ATT in such cases? From Dr. Kaushik. Yeah, thalidomide has been already answered.
Yeah, sometimes we keep following these scans after 2 years, 2.5 years also. Sometimes these lesions are enhancing. Recently, we have started doing PET scans. If they are PET negative, just a ring lesion, we are stopping the ATT after 2 years plus.
Are you giving a trial of pulse steroids apart from infliximab or tocilizumab?
If they're florid, like miliary kind of lesions causing severe raised pressure just because of the edema, because of the surrounding edema of these lesions, then yes. But otherwise, or if there is a severe optic nerve involvement, then we are giving it.
What would you suggest in this patient, sir?
So here they're not very florid, but they're causing mechanical obstructions are definitely there. So probably doing a shunt and then maybe thalidomide and then follow up. We need to follow up the vision very closely because it's very close to the optochiasmatic arrangement.
Yeah. Okay.
Okay.
Yeah.
All right. Thank you. Thanks, everyone.
Thank you.
All right, Razi, over to you.
Good evening. So this is a 1.5-year-old girl presented with baseline developmental delay. Currently, she was able to roll over, sit only when made to sit, and standing with support. Presented with seizure onset from 6 months of age. Initial uprolling of eyeballs and tonic posturing of all 4 limbs with bluish discoloration lasting for 30 seconds. Later, seizure semiology changed around 8 months. Epileptic spasms in clusters, mostly after getting up from sleep. Later started on medication anti-epileptics, vigabatrin. Later, around 14 months, hemispasms were noted, lasting few seconds. Frequency of seizures reduced twice to thrice per week. So, born to 4th degree consanguineous, full term, no perinatal issues as such. Only an ICU admission was there for 3 days in view of thrombocytopenia. On examination, head circumference was 39 centimeters, microcephaly, and some dysmorphism in the form of depressed nasal bridge, hypertelorism, and short stubby nose were there, and a few Kefiele macules were there, and multi-directional nystagmus was there, and bilateral early spasticity, TA tightness, and right-sided ankle clonus, and there was no weight-bearing presentation. So, a constellation of symptoms: global developmental delay with early spasticity and microcephaly with epileptic spasms, initially thought to be with background history of 4-degree consanguinity, any autosomal recessive epileptic encephalopathies, or any metabolic or genetic conditions or structural possibility was considered, and EEG was done. Twice, initially showing left-sided centrotemporal spikes and slow wave discharges were there. Later, it was repeated. It was showing modified hypsarrhythmia, and newborn screening was normal. So MRI brain was advised.
All right. I think we have two sets of images. Okay, one is an external scan. I have only the film images done last year. Age of scan, Razi, any idea? 1.5, so around 6 months.
Yes, sir.
Okay. I don't have ADC, but on the diffusion, if you can appreciate the central white matter and the periventricular white matter has some areas of restricted diffusion going up to the coronary data. In terms of diffusion, these are the main findings I've seen. And on the T280 sequences, you have this diffuse hyperintensities in the bilateral cerebral hemispheric white matter, more along the posterior hemispheres, some likely refractory changes or cystic changes expanding the underlying cortex, especially in the temporal and parietal lobes. In terms of the debrei nuclei, the signal changes appear to be normal on the T280 sequences. Yeah, these are the main findings one could appreciate on the T2s. Yeah, on the flares, the white matter changes, some of them demonstrate a reversal or rarefaction, especially along the subcortical regions. T1 beta sequence also, you have these corresponding hypointensity signal in what we have seen in the T2-weighted hyperintensities. And on the SAD sequences, you have some degree of hypoplasia of the pons out there, slightly which flattened. There is some degree of hypoplasia of the corpus callosum and possibly of the inferior vermis with the prominent cisterna magna. I think the 1-year follow-up images are better. I mean, the findings will be better appreciated. I think similar changes of extensive white matter abnormalities with subcortical changes are demonstrated in the, again, temporal and parietal lobes. Coming to the cerebellum, you have some degree of reduced volume, prominent folial spaces out there. And on the flare sequences, you have the cystic degeneration or refractory changes, again, which was seen on the previous study, but yeah, better appreciated on the scan. SAT sequence, again, you can appreciate hypoplasia of the corpus callosum. Now, posterior fossa structures, there is interval reduction in the volume of the cerebellum. And on the SW sequences, we don't have a CT. There were some punctate areas along the internal capsule, the subinsular white region out here, possibly raised the possibility of calcification. On the spectroscopy, I do not appreciate any significant peaks on spectroscopy. No lactates, no glutamates, NA choline, creatines are normal. So spectroscopy was pretty non-specific. Whole exome, yeah, Raji, what
So we have suspected hypomyelinating disorders based on the MRI findings. Full exome sequencing was done, which was showing OTC, ornithine transcarbamylase deficiency, which was X-linked, and likely pathogenic variant was detected. Then reverse phenotyping for this was done. Serum ammonia, ornithine, and citrulline was sent, which were normal.
Okay. So that does it rule it out, Raji, or given the labs are?
Yes, sir. Mostly, there should be some changes in the citrulline levels and ammonia levels.
All right. So imaging-wise, at least I could not match the gene with the imaging findings without possibilities of. This is not a hypomyelinating disorder because there are some cystic changes, some refractory changes. So it will be more of a genetic demyelination or dysmyelination, is what we have previously thought. And if there are calcifications, then I think interferonopathies and TORCH are possibilities. I don't think the child has any feature keratosemia, but again, subcortical cystic changes can be seen in those. Though cataracts also was not appreciated on this scan. Vanishing white matter disease and EF2B spectrum is what we thought, and mitochondrial such as RMND1 mutations can cause some particular cystic changes with white matter abnormalities. So these are the imaging differentials we had considered. If anyone else has any other suggestions or pointers, it will be appreciated. Thanks.
I don't have the diagnosis, just to remind that orotic acid is not a reliable biomarker for OTC deficiency. Definitely not. You can have OTC with normal orotic in the urine.
You could try a allopurinol loading test. That can help you diagnose OTC deficiency if it is actually there.
But the imaging doesn't match.
Yeah, imaging doesn't match.
Yeah.
I'm just saying because it's a pathogenic
Yeah.
variant. If it is matching, then if everything matches,
Yeah.
then it will be a case report sort of thing. Imaging is
Yeah.
not at all a OTC one. And even the clinical phenotype, OTCs have recurrent encephalopathy when they present with this stressors like febrile illness or a protein load, something like that. They don't present with seizures.
Yeah,
Usually.
there were no crises as such in the presentation. Usually, if infantile presentation of OTC, usually they present with febrile fever-triggered crisis. Usually.
Yeah, that's why. So not a clinical nor a radiological match. So that's why I think we should take genetics with a pinch of salt over here at least.
Right. And child Anas has ITPA, Anas, yeah, central white matter, I agree, but the other extensive white matter changes, no, may not describe. Pigopathy, again, similarly, you have central white matter changes and also brainstem abnormalities, but again, extensive white matter, no. Icardiogotres, yes, a possibility. Carlin says vanishing white matter, yeah, considered. X-linked adrenoleukodystrophy, it doesn't appear to be an X-linked, usually posterior hemispheric predominance. These cystic changes, rate factor changes are not typically seen. Yeah. What is the next step? Raji, now, since we have kind of concluded that it's not matching the likely pathogenic gene, reanalysis, or
Yes, sir.
are you getting a CT done, or is it not required, or we'll wait for reanalysis and then?
After the analysis, we'll take a call on CTs.
Okay. Right. So we kind of agree that OTC is less likely and other possibilities are to be considered. Yeah. Dr. Kaushik, Icardiogotres, Torch, temporal, yes, agree. In the differentials, thanks. All right, we'll move on to our next case. Harika?
This is a 7-year-old male child, born to third-degree consanguineous marriage and no perinatal issues. He has global development delay and intellectual disability. He presented to us with one episode of seizure at 7 years of age. That was in sleep, not associated fever. Seizure semiology was like abnormal localization with uprolling of eyeballs and tonic posturing of left hand with frothing, with teeth clenching lasting for only like 1 to 2 minutes, and with post-ictal drowsiness. And on examination, he had the dysmorphic features like broad forehead, long philtrum, and
Yeah, go ahead.
very thin upper lip, increased intercanthal distance, and clinodactyly, brachydactyly. And staphocephaly was also there, but no neurocutaneous markers, normal dermatoglyphins. And lumbar lordosis was present. He has a lower limb spasticity. There was asymmetric spastic diplegia, and on gait, there was right circumflexion gait was there. And there was aversion of both food while while walking. And this aversion was more on the right side. So in view of this intellectual disability, dysmorphism, and asymmetric spastic diplegia, and this pyramidal signs, MRI was done initially.
Okay, I'll just finish, waiting for the video to finish. All right. You want to come back after the MRI?
Because he presented with seizures, we have done EEG that was showing posterior dominant spike and wave discharges in runs with the longest burst being 4 seconds and intermittent forehead activity of spike and slow wave discharges that were reduced significantly during awake state. And because of intellectual disability, we have done IQ assessment that was 74. That was corresponding to borderline intelligence. And he has the speech and attention issues.
All right. Coming on to the MRI diffusion ADC sequences, the main findings, if you see, are in the pyramidal tracts or corticospinal tracts in the posterior metal capsule. They are the symmetrical areas of high signal changes on the diffusion varied sequences moving up to the subthalamic nuclei. Does not truly restrict or reverse on the ADC sequences, so some degree of T2 shine through out there. And on the flare sequences, you can appreciate some punctate white matter changes. I think these are pretty non-specific in the frontal white matter, but again, you have these symmetrical areas of T2 hyperintensity in the posterior metal capsule. T2 varied sequences also demonstrate the main findings or which you appreciate again in the clicks on both sides. Yeah, other than that, there was no cortical no malformations per se, and no other focal lesions of significance. These areas do not restrict and do not show any abnormalities of the SWS sequences in terms of blooming. On the imaging possibilities, we thought of the main changes were in the corticospinal tracts, in the pyramidal tracts, and the differentials we had given was these differentials were given Krabbe's disease, motor neuron disease, lateral sclerosis, mitochondrial TRA disorders, HSP spectrum were considered on the imaging aspect. So yeah, Harika, over to you. I think whole exome sequencing was done.
Yes, sir. Whole exome sequencing was done. That was showing TPP1CB heterozygous mutation. This is Noonan syndrome-like disorder. And other mutation was the DPYD heterozygous autosomal dominant mutation. So we have done parental segregation also. This PPP1CB was found in father also, though that was ruled out as cause.
And DPYD also is not significant as a.
And like this phenotype is also not matching with this genotype. So any other differentials or any other matches possible for this phenotype?
Yeah. All right. Cases open. Let's see. Sridhar has already mentioned. Sridhar, you want to just point out?
Yeah, similar phenotype with spastic diaparesis and epilepsy. Two urea cycle disorders. One is arginine deficiency and arginine lyase deficiency. Both of them present with the clinical phenotype of spastic diaparesis with epilepsy in a child who has no perinatal risk factors. Usually, spastic diaparesis is a phenotype of premature neonate acquired. But if you see in a term neonate with no parental risk factors, third degree consanguinity epilepsy, two clinical differentials which come to my mind are arginase and arginosuccinate lyase deficiency. So I think some metabolic phenotyping on those might help because they have this posterior predominant epilepsies. I think Dr. Ramshekhar Menon is a series from India in which he presented these cases of urea cycle disorders presenting with epilepsy, in which the EEG showed a similar phenotype, the posterior predominant spike wave patterns. Some of them were like SWAS pattern also, and this corticospinal tract involvement. Another Krabbe also I suspected but Krabbe's usually have myoclonic ataxia phenotype. They have more of myoclonus and falls than ataxia. This child had a tonic-clonic seizure, as far as I could remember. So, yeah, this others same.
So Anil says it could be artifactual. Is that a possibility?
No, I just thought that is usually seen on DWS and ADCs. The spinal tracts are slightly hyperintense, but these are evident.
Thank you.
Yeah, so it's two abnormalities, but yeah. Yeah. Okay. So we conclude that the genes do not match the imaging phenotype and also the clinical phenotype. The possibility is mentioned here, and also as Sridhar has added. Yeah, I think those have to be valid.
So sir, we'll work up for this arginine deficiency.
Okay.
But
all of these are
genetic is negative, no?
Negative.
Yes, sir. Genetics is negative.
Any other possibilities or thoughts? Let's see. Okay. Normal ammonia levels in symptomatic neonate excludes urocycle disorders. Right. Okay, I don't think we have any other thoughts. Okay. Yeah, okay, kind of stuck, but we agree that at least the genes don't match the imaging findings. And other possibilities to be considered.
Yes, sir.
Okay. All right, Harika, over to you.
Okay, so this is 13-year-old male child born to non-consanguineous couple with no perinatal issues. He had global developmental delay with motor speech more than that of cognitive delay. He also has bilateral lower limb spasticity with brisk DTRs and spastic ataxic gait on examination. He has a sibling. This child is 4 years 8 months old. This child also has global development delay, but less than that of this elder one. Motor more than that of cognitive. This child also has mild gastrocnemius spasticity with brisk DTRs and crouch gait. This child, at the time of birth, the ambiguous genitalia was identified where fused labia with single urogenital sinus opening and no palpable gonads and small phallus was identified at the time of birth. This is a index child, this elder sibling. And this child, younger sibling, is raised as female.
It has similar clinical phenotype.
Yes, similar phenotype, but she is now
Raised as
4.5
female.
years, like milder phenotype compared to that of elder sibling.
Okay. All right, so we have the imaging of the elder sibling. Okay. Imaging findings predominantly in the posterior fossa, cerebellar atrophy, hyperintense cerebellar cortex on the flares signals, some degree of hypoplasia of the brainstem structures, also hypoplasia of the corpus callosum, no structural abnormalities in terms of malformations in the supratentorial brain, some focal abnormalities in the centrum semiovale frontal white matter, non-specific in nature. So no other findings, no abnormal increased mineralization on the SWS sequences. So these are the main findings, main sequences: cerebellar atrophy, hyperintense cerebellar cortex, hypoplasia of the brainstem and the corpus callosum.
So for elder sibling, genetics was done. That was H2 TOE1 exon 6 homozygous mutation, PCH7, that is pontocerebellar hypoplasia type 7, autosomal recessive type. And because of this ambiguous genitalia, for elder sibling, karyotyping was done. That was showing like 46X5 type DSD. And ultrasound abdomen was showing bilateral peak gonads with absent Mullerian structures and blind ending pouch. And her this elder sibling, endocrinology workup was done. That was normal till now. This younger sibling was having all low anti-Mullerian hormone and low testosterone and low hydroxytestosterone.
Okay. So PCH7, we tried the at least as per Dr. Srikanth, the clinical phenotype matches abnormal genitalia and other neurological features demonstrated are matching with both the siblings. And this is from the paper of which Dr. Bolthauser has co-authored. As you can appreciate, these children have pontocerebellar hypoplasia, can have cerebellar atrophy with hyperintense cerebellar cortex, and abnormal genitalia are the main features. And imaging findings, the list is wide for cerebellar atrophy with hyperintense cerebellar cortex, but PCH type 7 is one of the imaging differentials. With that, I'll open the case if anyone has similar experiences. Do they agree that these children match the PCH7 gene? And any other thoughts?
Just a question. I may have missed the point. So the younger sibling had also exome sequencing or just the elder sibling?
Sir, elder sibling was done. That is H2 of this pontocerebellar hypoplasia type 7.
I understand, but the younger sibling was also tested, or this
No,
was not?
younger wasn't tested. Only karyotyping was done.
Okay, Thank you.
So again, you agree with the findings? I mean,
Yes,
since
I
it's
think
your
it's
domain.
it's a reason. It's a good match.
Younger sibling doesn't have imaging, but I think one would expect the similar findings.
I mean, the question is about, I mean, the cerebellum is abnormal, definitely, and the cerebellar cortex hyperintensity. The pons, I'm not that impressed. The pons is a little bit short, but the pontine protuberance is not bad. This just shows that the term pontocerebellar hypoplasia is can be kind of a misnomer. It's not a very useful term. But I mean, this is a historic term. This type 7 has an OBIM number. You cannot change it, but it's not an optimal terminology.
All right. Yeah, Sridhar added COFG syndrome. Yes, Sridhar, that is one of the main possibilities with posterior fossa abnormalities. Again, both of these findings are highlighted on that review paper by Dr. Bolthauser. So the main findings with PCH or cerebral abnormalities with abnormal genitalia, COFG, and PCH7, the two main differentials. All right. Yeah, we just wanted to confirm the match.
Very informative.
Yeah. Thanks, Agam. All right, Razi, over to you.
This is a 2-year-old girl presented born to non-consanguineous parents and normal development with history of involuntary movements of right shoulder jerking. What they have noticed, almost 6 months back, they have noticed this when they have presented to us for the first time. It started with fever triggered, then the child started to have this right shoulder myoclonic jerks, 10 to 15 per cluster, and 5 to 6 times per day, each episode lasting for less than 1 minute. Then they got admitted, and initial possibilities of infection or para-infectious or demyelinating causing segmental myoclonus was the possibility, and initial MRIs were done. MRI brain, they got it done also. Then MRI spine, we got it done at our center.
Sorry, I don't have the brain images. Anything on the brain, Razi?
Brain was normal.
Sorry, Anas. Yeah. Okay, so spine, you have these at least cervical cord myelopathy was demonstrated on the spine sequences. You have these hyperintensities of the T2 sequences. I think the thoracic ones are more artifactual, which do not corroborate with on the axial images, but you can appreciate on the cross section. I mean, the axial image of at the cervical level. We have almost the entire cord demonstrating these T2 hyperintensity changes. In terms of contrast, they did not demonstrate any contrast enhancement. Even the cortical nerve roots, I think only 1 or 2 demonstrate mild enhancement. No significant abnormalities in the cortical nerve roots. No other changes in the soft tissues or the bony or the vertebrae. With that thought, we thought of infectious, post-infectious demyelination, transverse myelitis as the possibilities at that point of time.
Yeah, this was the video.
So completely ruled out. I mean, the labs had ruled out.
Yes. CSF analysis was normal. NMO MOG was sent for demyelination, which was negative. Child was started on IV methylprednisolone pearls course for 3 days, followed by maintenance was given for 2 months tapering schedule. Sir, can you play this video?
Yeah.
He was having only the shoulder jerking myoclonic jerks, which used to be there for almost 1 minute. So post treatment, after discharge in 2 days only, this shoulder myoclonus subsided, reduced in intensity, almost very infrequent. Later again in April, child had fever triggered, again recurrence of this segmental myoclonus of right shoulder only. Then third episode, recently they have visited us again with fever triggered this right shoulder myoclonus. So we have repeated this MRI spine during this time.
Okay. MRI spine, so after 6 months of the initial scan. Again, you can appreciate cord myelopathy, but these are the sections along the thoracic cord. There is some interval progression in terms of signal changes, especially along the ventral aspects. of the thoracic cord. The cervical cord changes are pretty similar to what we have seen on the previous study. And on post-contrast sequences, there was some enhancement of the cardiac nerve roots, but no enhancement of the cord abnormalities, which was demonstrated on the initial scan. Also on the scan, there was no enhancement. So some interval progression in terms of involvement of the thoracic region and some cardiac nerve root enhancement, which was not significantly seen on the prior study. So everything has turned out to be negative in terms of the inflammatory infective workup. Is that right?
Yes, sir. We have repeated a few labs recently when they have visited ESR and TMS biotinase along with plasma lactate, which came out to be normal. TMS is awaited, but biotinase and lactate and ESR is normal. Initial lab workup, CSF analysis, and infective workup and inflammatory and demyelinating workup was negative initial.
So the question was, I think, do we go ahead with genetics as one of the possibilities, or any other changes? Is it vascular? Though there was no enhancement in terms of the leptomeningeal vessels or the perimedullary vessels, no AV fistula type of changes. So yeah, we kind of stuck, and we appreciate any inputs and thoughts.
Yeah, Sridhar here. I have two possibilities. Either it's a spinal cord tumor like a pilocytic astrocytoma, because they present with this segmental myoclonus sort of phenotype. And second thing is subsultus tendinum, fever-related myoclonic jerks which subside as soon as the fever episodes are gone. And because we have a imaging abnormality over here, I would likely go with pilocytic astrocytoma. I think before biopsy, we should go before genetics. We should go for a biopsy of the lesion.
Okay, I kind of disagree with the pilocytic one. But yeah, I mean, there's no mass.
Yeah, not. I don't know the tumor type, but yeah, something. If it is not inflammatory and not infectious, then I don't think it's a genetic thing which is causing this. Spinal segmental myoclonus is usually acquired disease. It's not a genetic disease. So, yeah, biopsy should be the priority before genetics. That's what I wanted to convey.
There is no mass effect anywhere, isn't it? So that's why we were thinking.
Yeah, I wouldn't say. I mean,
yeah.
In theory, it is a possibility, but I think imaging wise, I would say it's not very less likely for a pilocytic.
Yeah, I think any kind of inputs later on as well in the group is very much appreciated. They're not able to get to any diagnosis and help this child. Thank
you. SMA, Dr. Lokesh, you have seen SMA with myelopathy recently and cardiac enhancement.
No, that's an issue. He's having only this right upper limb, right shoulder segmental myoclonus. Nothing else is coming as a clinical manifestation and no element signs.
Can this be something infiltrative?
Everything has turned out to be negative. Like, sorry,
like sarcoid or something?
Possible. I mean, inflammatory.
Yeah.
I think Lyme was tested.
Lyme is negative, yeah.
Lyme is negative.
Yeah.
Yeah, but you would agree that tumor is less likely, right, Anish?
Yeah, I agree.
Yeah.
Tumors could have some serous formation.
Thank you.
Yeah. All right. Okay. All right. Yeah. If anyone has any other inputs, you can put it on the WhatsApp group later on. MRI suggests chronicity anasas. Yeah, it was there on the initial scan and also now with new interval changes. Cord appears to be slightly reduced in volume compared to the previous study. So there's no swelling or so acute. It's not acute in nature. All right. We'll move on to the next case. Yeah, Razi, over to you.
So this is a 8-year-old male child presented with no perinatal issues, normal development prior to that. History of left focal motor seizures started initially. Only jerking of hands were there, but he was able to carry out daily activities. Intermittent fever spikes were persistent. Almost. And then he developed a left upper limb and a lower limb weakness as well. And then child started to have right-sided upper limb distal jerking movements of hand. That was in hospital after admission. But past history, he was having like recurrent CSOMs. Two times he had CSOM and recurrent hospitalization since infantile period. Almost like once a month admission for 5 to 10 days in view of recurrent pneumonias. With this background history of recurrent infections, pneumonias, and CSOMs, with possibility of immunodeficiency, outside workup was done, and initial like lymphocytic subset analysis was also done for this child, which was showing NK cell deficiency. But immunoglobulin levels were normal. Now this child with almost ongoing fever since past 10 days, and to begin with left-sided EPCs, distal EPCs, then it progressed to involve right-sided EPC.
Right. Yeah, so the imaging findings, the diffusion ADC sequences, we have some changes in the perironic region, the cingulate cortex demonstrating restricted diffusion. Coming inferiorly, you have the perisylvian region also has the focal areas of abnormalities in the cortex in terms of diffusion changes. On the ADCs, you have reversal, especially on the right side, the right perironic region, the red cingulate cortex, subcortical white matter out there. And also the perisylvian regions demonstrate some area, the focal areas of reversal on the ADC sequences. There was also some thalamic abnormality on the right side again, which shows some marginal degrees in the ADC sequences. On the flare sequence, you can appreciate the cortical and the deep brain nuclear abnormalities. Again, cortical edematous changes in the bilateral perironic regions, more on the right side, the right parafalcine cortex out there, the perisylvian regions, the right thalamus, and the internal capsule. Possibly also in the medial temporal lobes, they were slightly hyperintense, and the posterior fossa structures in terms of signal changes, no abnormalities out there. Yeah, T2s again demonstrate the same changes. The anterior basal ganglia also, the T2s on both sides appear slightly hyperintense. If you compare that with the putamen, which demonstrates normal signal changes. So cortical edematous changes and deep brain nuclear abnormalities are the main findings, with some degree of volume loss, some folial prominence, circle prominence in the background. None of these demonstrate any changes on the SWA sequences for hemorrhage or calcifications. Spectroscopy was done. A very mild peak around the mild lactate peak out there. This was placed in the thalamic abnormality. In terms of SAT sequences, possibly mild hypoplasia of the body of corpus callosum, not very significant, but you can appreciate the folial prominence along the vermis. Yeah, Raji, what do you?
Yeah, CSF analysis was done to rule out infection because background history of immunodeficiency, which was like showing 4 cells, all were lymphocytes. And CSF next generation sequencing for virifast was sent, which was suggestive of Simbu-orthobunia virus.
All right, so imaging wise, we do not have any experience of this virus, but they, as mentioned in the literature, they have mentioned that cortical edema and in general viral infections, deep brain nuclear changes can be seen. The other imaging differentials we thought was possibility of pathology given the cortical, especially the perironic region abnormalities and thalamic abnormalities. So Raji, does it? I mean, is there any developmental issues or any regression after the illness?
No, sir. But child is a bit encephalopathic, drowsy because of consistent to have like seizures on midazolam infusion as of now, and left hemiparesis and left UMN facial weakness as well. But prior to that, development was normal. And while at presentation to first time in OPD, he was walking around with that EPC as well. And initial EEGs were showing right-sided hemispheric slowing. Later, we repeated EEG when it evolved to involve right side as well. It was showing like time-logged like spike and slow wave discharges were time-logged to this EPCs, which were captured on EEG as well. With right-sided slowing, there was worsening. bihemispheric diffuse cerebral dysfunction on EEG. So whole exome sequencing was sent for this child in view of PID workup.
Okay.
But yeah.
Negative or awaited?
That is awaited, sir, like 5 days back.
Okay. Anyone has any experience with Simbu orthogonia virus imaging or manifestations, clinical manifestations? I think that the hosts are as mentioned out here, cattle or even bats. Any exposure, Razi?
Yeah,
to
cows are
cows?
actually one of the hosts, and
Yeah.
Anopheles mosquito transmits actually. So it is. We have had around 6 cases now with neurological manifestation. After using the metagenomics, we are able to pick up this. Actually, there is a huge list of how you define the causality that it is because of this. So there are a lot of other investigations to be done, and we have sent the samples for cross confirmation to NIV Pune. We'll wait for those results also to confirm, because this was one of the in last almost 6 weeks. This is the third case in our institute, and in Apollo as well. They have had similar incidences with CNS and other systemic manifestations as well, with only this virus being flagged up in the metagenomic studies. And similar experience probably in Chennai, Apollo as well has been there, but it has only a personal communication, not been published.
And EPC noted, Dr. Lokesh, or is it not specific for these viruses?
Very non-specific manifestation. Okay. The other child had cervical cord once again involvement with faciobrachial weakness kind of manifestation. Then had cardiac involvement, myocarditis, and then later on he died. So very varied manifestation.
All right. I think yeah, many of the people in the chat have not seen these viruses.
Yeah.
Dr. David asks availability of very fast and cost.
Yeah, so it is if you negotiate with them, they are doing a very fast for 14,000, 14 to 15,000 is the cost for very fast. Back to fast, I think around 12,000 or so. So that is, I think turnaround time is around 3 to 4 days. I think definitely much useful than the usual standard PCRs what we have been doing.
Yeah. All right, so we'll await for the confirmation. Dr. Lokesh from Pune and
from Pune and the genetics as well. Yeah.
Okay. Yeah. So we just wanted to highlight this case of this emerging viral infection, and if anyone comes across it, you can just send the cases over to us, and we can discuss it over at this panel. Yeah, if there's nothing else to add, I think that is our last case. So thank you once again, everyone. Hope you can send in your cases by 1st of July. We'll meet again on the 4th of July.
Thank you.
All right. Thanks.